So as the patient loses 85% or more of their kidney function, they're now in stage 5 and are awaiting dialysis. A slew of problems will result. One will be anemia, because again, the kidneys are responsible for the hormone erythropoietin. So that is no longer released. So the patient will have chronic anemia. Periodically, they will require blood transfusions, which we discussed today in lab. Bone disease, because of the kidney's inability to reabsorb and control calcium levels. Okay. Hyperkalemia, obviously, kidneys excrete how much percentage of our body's potassium? 80%, right? So that 80% elimination of potassium, that function is no longer present. So the patient is forever at risk for hyperkalemia. That means these patients miss 1 or 2 dialysis sessions. What will they have to be coming in for? Hyperkalemia already. Okay, not to mention fluid overload at the same time. But which one will kill them first? Fluid overload or hyperkalemia? They'll just go into cardiac arrest, okay, at home. So they have to follow a certain diet. This will be prescribed by a professional, a dietitian, nutritionist, in coordination with the nephrologist. Hypertension, this is now going to be chronic. So these patients will have multiple blood pressure medications. Diuretics will be just one of them. Then they'll have calcium channel blockers and ACE inhibitors as well. Okay. And then these are some complications related again to the toxicity, the acidosis, which can predispose them to pericarditis. We'll discuss all of these three later under module 9. No, module 8, sorry. So management will be to manage these chronic complications. Not to mention renal replacement therapy, which is now dialysis. So these are the drugs that they'll be taking daily. So you'll expect to have 20 or more medications listed on this patient's pharmacy list. So if you're in clinical, then your instructor assigns you this. You'll be writing a lot in your drug card. Okay, so they'll have a minimum of 20 because again, are these patients just having end-stage kidney disease? Do they only have chronic kidney disease? No, meaning they had disorders that led to this. What are those again? Diabetes, hypertension, okay, or other conditions, or let's say lupus. Lupus could also lead to CKD. So we're also addressing those medications, okay, that led to the CKD. So the CKD medications are one set, and then it's another for whatever led to that condition, okay? So it's a lot. These patients are always have advanced directives, or they should have advanced directives because at any time they decide, let's say, can this patient just go suddenly get depressed after one event, for instance, let's say a fight with a spouse, or let's say a child says something. Okay, will it affect the patient emotionally? Yes, and then they'll just decide up and say, no, I'm not going to dialysis. I'll just stop. Well, they'll disappear. Then, no, the family will call the cops. We can't locate this guy. And then here we are. Somebody will call. They're at the bar, passed out. Okay, missed a weeks of dialysis, for instance. Okay, so no, they'll just totally give up. Right. So these things can happen. So these are the pictures you'll see in these patients. Okay, and it's not a one-time event either. Okay, so things will happen throughout their lives because their days are literally counted, correct? Meaning they're just counting their own borrowed time. Okay, without dialysis, then they'll die. Okay. And this is forever. There's a kidney transplant list, but you know how that works? Yeah, you can't really get a kidney at a grocery store. Okay, so it's a long list. Okay. So here are the common medications. They come in packets, also tablets. Okay. Just a warning because of the number of medications you have. Please don't take shortcuts when giving medications. Based on experience, always scan your medications before you give them. Clear? That's for your protection as much as the patient's. Okay. You don't want to come later. Oh, you ended up giving too much of the medication. Okay, because the pharmacy will send you everything for the whole day. And let's say calcium acetate, right? So this one, you got calcium phosphorus binders. So they give you calcium acetate. They give you the whole 8 pills for the day. They don't send it to you, for this is for the 10 o'clock, this is for the noon, this is for 5 p.m. No, they send you everything for the whole day. And the patient takes it 4 times a day. Okay, and then you might end up giving the whole because it's in the drawer. All right. Then you end up killing the patient. So antihypertensive, as already mentioned. And again, heart failure can result. So they may be on beta blockers as well. We discussed heart failure medications already last week. And those are another group of medications. Okay. So these patients, can this be depressing? You're taking pills. Yeah, a lot of pills. And these injection, okay, these are once weekly injections. So this is a good alternative to blood transfusions. Because what did I say this morning? The more blood transfusions you receive, the higher the risk of a reaction. And then one of those reactions will eventually cause death, okay, despite our best efforts. Plus, if the patient has any restrictions to blood transfusion as well. So erythropoietin injections are your best option. Nutritional therapy. This is probably the hardest to comply with, the diet. Okay, can they eat pizza? No, one slice of pizza would exceed the daily requirements already for the protein, fat, potassium, sodium restrictions. Just one slice is going to exceed. So they can't enjoy these things anymore. Okay, so say goodbye to pizza. They probably could still eat pizza, but it's gonna have to be custom. Okay, so they'll have to really customize the ingredients. Okay, which will cost more. Yeah. So you can't get the $7.99 2-topping pizza deals anymore. And here's dialysis. So we'll discuss the details of dialysis today. So for nursing management, what is the fluid status of CKD patients? Deficit or overload? Overload. For how long? Forever. This is permanent. So your interventions would, of course, be toward addressing fluid overload, and not to mention the electrolyte imbalance, particularly potassium. Okay, so that's what you'll be assessing. Patients' fluid intake, diet intake, are they compliant with diet, with the medications? And as far as the nurses go, are you measuring the intake and output accurately? Are you weighing the patient every day? Okay, are you monitoring the blood pressure? Are you monitoring the laboratory results? So it's a busy patient. Here's a nice nursing care plan addressing all of them. It's a long list. I'll leave you responsible for that. So they'll go into each nursing diagnosis. Let's say here from knowledge deficit, and then fluid overload, electrolyte imbalance, activity intolerance because of the acidosis. Not all, but most patients will be on bicarbonate. No, because can we do dialysis every day? Hemodialysis? No. So in between dialysis days, they will go into acidosis. So that's why they'll be on bicarbonate daily. Okay, let's go into details of dialysis. Dialysis falls under renal replacement therapy because there are no more working kidneys. We'll have to do alternatives now. There are two. There are two forms of dialysis. We have hemodialysis as well as peritoneal dialysis. Hemodialysis can have three different types. Okay. So for hemodialysis, it can also be CRRT. CRRT is only reserved for unstable patients, meaning this is only done in the ICU. CRRT stands for continuous renal replacement therapy. It says continuous because it runs for 23 hours. Okay, there's a 1 hour break just to change the tubing, change the set, but it's literally nonstop. Okay. It's done slowly over 23 hours because the patient again is unstable. So we are unable to remove large amounts of fluid and electrolytes at one time. So that's why it has to be slowly over 23 hours, meaning the patient's body has no idea or cannot tell that there is fluid removal. Okay, so it's that slow. So the changes are very slow, very subtle, so the patient won't go into full meltdown, meaning cardiovascular compromise is not there's a very low risk for that. So what will dialysis remove? Potassium, excess fluid, reducing risk for pulmonary edema, meaning heart failure, and acidosis also will be addressed. Pericarditis and uremia is basically accumulation of waste products in the blood, which can cause um, brain damage, will cause encephalopathy. So before we started dialysis, the patient will be educated repeatedly. They will be encouraged to join a support group. Okay, so there'll be a dedicated educator on the floor, talking to the patient and the family. We have to include the family, of course, because we can't keep the patient in the hospital, right? So the family must be on board with the plan that this is going to be forever, right? This is not something short term, and they have to understand their role as well, which is to support the patient. So can this change the family dynamics? Yes, let's say this patient was the breadwinner. What happens now? Okay, so initially, if the patient is on board, they can actually continue employment. So I work with a couple of, well, not a nurse, but he's a CNA, and he's on dialysis. Sometimes he's non-compliant and ends up on our floor. Okay, and it's the worst thing, to take care of a colleague. They know you, they don't really, and then it's kind of awkward. Okay, when that happens. But it happens. I mean, life goes on. They're human too, so not everybody is compliant. So signs of uremia are the following. So basically, this is not only for uremia, but any metabolic acidosis, okay, condition. Nausea, vomiting, severe anorexia, lethargy, meaning the patient has decreased mental level of consciousness, okay, and then altered mental status. They have confusion. They could be violent, okay, or they could also be unresponsive. It depends on the level of the severity of the acidosis. As already mentioned, this should be discussed because yes, we can reverse this and the patient can stop this altogether, okay, depending on the patient's advanced directive, but it can be a circus. Okay, that's how I would describe it. If the patient has no advanced directives, because even if they have, I mean, there are conflicting interests, right? So let's say this patient has a very good pension and they have survivors. So is there an interest there with the spouse, surviving spouse? Yes, if the patient decides to stop dialysis, what happens to the pension? See what I mean? Okay, so there could be conflicting interest there. So let's say the surviving spouse has no employment. They're depending on that same pension. You know where I'm going with this, right? So yes, there's a lot you don't want to deal with, but you're placed in the middle. Okay. So I usually pass it on to the social worker. I just say, oh, I have to go next door to a patient. I'll be right back, okay? And then I don't come back for 2 hours. Oh, sorry, so busy. Okay. Because I don't have to, it's not really my problem, right? So I mean, deal with it. Okay. So you guys um are giving me problems. Okay. So transplant would be good, okay, if you get a donor eventually, and then we'll talk about transplant and transplant rejection management next semester. That's a different topic, a long topic actually. So let's talk about the most common type. So majority of patients go with hemodialysis. We'll do a side-by-side comparison. There's a table later and a chart, I think, and then talks about advantages and disadvantages of each. Hemodialysis doesn't have to be for end-stage kidney disease. We discussed this in AKI, correct? So it could be short-term. This could be here short-term for a few days, 2 weeks in AKI, or forever in CKD and ESKD. Take note, hemodialysis prevents death, meaning prolongs the patient's life, but there's really no cure. The only cure would be a kidney transplant if they're lucky enough to receive one. No, luck means sometimes means they have money, right? Okay, yeah, because I mean, oh,
His wife gave it to him.
huh?
His wife gave it to him.
Who got a kidney transplant? You did?
My dad.
Oh, your dad. Okay. Who gave it to him?
His wife.
Oh, they're a match? Oh, okay. Oh, by the way, FYI, even if you're not a match, but you're a willing donor, it can be made possible because we have exchange. We have an organ exchange network, meaning, yeah, as long as there's a willing donor, they're willing. Oh, they'll find you with another patient somewhere in another state, and then they'll swap you with another that is a match for you. Okay, yeah, there's a program like that. Yeah, and it's a federal thing. Yeah, yeah, as long as you have well, it's not free. Nothing's free, man. Huh? Well, if if you have insurance, it'll cover it, but somebody pays for it, But it can be facilitated. Like, let's say, look at Alonzo Mourning, right? So he suddenly got a match, right? I mean, no comment though. I mean, let's just face it. That's reality. Okay? There's it can be facilitated, right? If you know the right people. And by knowing the right people, that means you have money to know those people. Yeah. Okay, so hemodialysis. So we have a machine now called a dialyzer, which is an artificial kidney. So it's a machine, uses the processes of osmosis, filtration, and ultrafiltration in order to remove waste products as well as excess fluid and excess electrolytes. Okay. So here, diffusion, osmosis, ultrafiltration. I don't want to go into detail again on the NCLEX test plan. What's on there? Oh, let's see. So you'll be tested only on, let me specify, the did you save? You should save the NCLEX test plan already on your desktop. I mean, it's a PDF. Okay, you should have it on your tablet. Okay, here we go. So if we search the document, Okay, our hit says perform and manage the care of client receiving peritoneal dialysis. Okay, so which one are you expected to perform? Peritoneal. Okay, so if you look at all the hits, because there are 6 hits here on dialysis, for hemodialysis, all you're expected to know and be tested on is managing the care of a patient receiving hemodialysis. Does that make sense? Is that the same as performing hemodialysis?
No.
Not at all. So meaning you're not doing the hemodialysis, but you can do the peritoneal dialysis. However, since you have the patient before and after dialysis, then you have to know how to manage the care of a patient receiving hemodialysis. Does that make sense? Okay, meaning you have them before and after hemodialysis. You're not doing the hemodialysis, meaning they're outside your care during hemodialysis. They're under the care of the dialysis nurse. Okay, and then after dialysis, of course, you assume care again when the dialysis is finished. Okay, does that make sense? Okay. Um, that's what we'll focus on. So I'll skip how it works. If you want, there are YouTube videos. So let me just describe how it works. Okay, so 2 needles. We'll talk about the access device later. So 2 needles will be placed, and then 1 needle, just like with the plasma pheresis or with platelet pheresis also. Although we use 1 needle for platelet donation now. So here we have 2 needles, 2 large needles, because 1 needle will remove blood. It will go into the dialyzer. While in the dialyzer, we will remove what is removed? Fluids. Okay, excess fluids, excess electrolytes, waste products will be removed, and then the rest of the clean blood will return to the patient. And that goes on. If it's hemodialysis, the session will be anywhere from 3 to 4 hours, depending on the patient's tolerance. It may be cut short if the patient does not tolerate the procedure, but the pre and post procedure will be similar. There are big dialyzers. There are also small dialyzers. We have home hemodialysis now. This can be done at home by the patient themselves. Okay. But it's a separate setup. The patient would be educated, of course, how to do it. But because it's a small dialyzer, it will only remove maybe a liter every day. So it has to be done every day. Okay, so that's the downside of a home dialysis. But some people like it.
Are they doing it for the same amount of time? 3 to 4 hours?
No, shorter also. Because these patients continue to work. No, they're at their job and then they come home, perform the procedure after the work is over. All right, so our job will be, since we're not performing the procedure, our responsibility are over 1, the vascular access. What is being used for hemodialysis? So we have to know how to assess and care for that dialysis access. Second, we will monitor the patients for complications before and after the procedure. And then finally, we will also have to manage the medications. Remember, how many medications are we expecting here? Too much. Okay, too many medications. Okay, let's start with the vascular access. So look at the rate of cleaning. The dialyzer will clean 300 to 500 ml per minute. So what type of vascular access are we talking about here? What do we need? If it needs to remove and return 300 mLs per minute, small or big? We need a big needle. We need a big access, right? Okay. So let's talk about the vascular access device. If we need it fast, meaning emergency dialysis, we need it now, we will have to use, remember central lines on week 1? Okay, so we will have to use tunneled or non-tunneled. We need it now. Non-tunnel. Okay, so non-tunnel will be used for immediate, for emergency purposes, because we can have a non-tunnel in under 10 minutes. Okay, really fast. Okay, so they can insert it right there at the bedside. 10 minutes finished, then ready for use. Okay. So they can use the femoral, the subclavian, or the jugular for that. Okay, non-tunnel. For long-term use, of course, we'll use a tunneled catheter. So here is a tunneled catheter. Why is it tunneled? It's not here. So we have two insertion sites, right? We enter the patient's body here, and then we enter the vessel right here. So that's a tunnel. Long-term use, if that is the intention. Let's say, because the fistula, if that is the long-term plan, is not ready for use right away. It'll take months, years, extra years. Okay, so we don't know when it will mature. But until then, we will have to have an alternative. That alternative will have to be the tunneled, okay, tunneled hemodialysis catheter. So most cases start out that way. Okay. So the long-term and more natural will, of course, have to be a fistula. We can also use a graft. A graft will be an alternative, but most patients, because between the two, a fistula and a graft, the fistula is really the long-term option, meaning it's the best option, and it will last for decades. Okay, so what they'll do is do a vein mapping, vascular mapping first. So the vascular surgeon will order a ultrasound for vein mapping. So they'll look for the best site and the best size, okay, blood vessels where they can, so they will surgically connect an artery and a vein. So that's what we have to look for, the best option. And then once they find that, then the vascular surgeon will do their thing. They'll send the patient to the OR and create the fistula. If the graft is the option, then that's a graft right there. So they'll put an artificial graft connecting an artery with a vein. See the connection? Okay. So this one we surgically created and then wait months to years for this to become big. This will grow because you're exposing, basically the concept is you're exposing the vein side to the pressures of the artery. Arteries and veins are not made the same, right? I mean, arteries are tougher, veins are more feeble. Yeah. So the pressure also is higher here. So when you connect them, of course, you're exposing this part of the vein to the pressures in the artery. So that will grow. That will grow and then get bigger and bigger. But now you have a big vessel. You can't miss that. I mean, you stick that, you close your eyes, there you go. Okay. Yeah, they're big. I mean, you can't miss it. You poke it repeatedly with large needles, they're okay for use. Okay, so that's the objective here. This one, you target the graft now. Okay, because now you connected the artery to a vein via this graft. So you're going to stick the graft. Okay, but the grafts though do not grow. Okay, unlike fistula. So fistulas are better compared with the graft. But we take what we can. We take what we have. Okay, so a fistula, the most commonly used access device. Your responsibility here is to protect it, okay, until it matures. And once mature, guard it with your life because the patient's life literally depends on this fistula. So what do we not do with it? Okay, don't do anything to compromise that fistula. So you want to maintain its circulation. You want to be making sure it works. We'll look at your assessments in a little bit. Okay. Responsibilities will be a separate page, but this is again the longest useful life. Okay, so almost permanent. almost permanent because this can also go bad. Okay. But not likely. Graft, short-term use. Okay. So here, why is this option chosen? Well, if the vessels are not suitable, meaning they have no big veins or arteries, they're too small. So no, some people's arms just don't have the adequate size blood vessels for fistula, so they end up with a graft. That's the best thing we can do. So most grafts don't last long, just a few months, and then goes bad. Once a fistula or graft goes bad, of course, we have to use what? A catheter, okay, a central line. So they come into the hospital, we give them a tunneled or a non-tunneled, and that's the only way they would get their dialysis. So if they have the access device, fistula or graft, this will be placed on the door, on the wall, letting everybody know. Okay. And also, my practice is I put the blood pressure machine on the side opposite that graft or fistula. That way, are you likely to take it on the opposite arm if it's on this side? No, because technically you would instinctively you're on this side, so yeah, so you'll use the same side, right? You're not gonna cross over to that arm. Yeah. Uh, as long as the patients are alert oriented, though, they already know which arm to offer you for blood draws or for blood pressure. Okay, they already know. Because literally their life depends on it, so they have to care, right? Unless the patient has confusion. So you put that, and we have these signs already laminated. Okay, they're ready for posting. Okay, we already have that. It's just a matter of whether it's left or right arm. Okay, and then we have the same also for mastectomy. So either when you see these signs, either the patient has either a mastectomy or some fistula or graft. Because we use the same signs. I mean, we have the same restrictions. For the case of a mastectomy, it's because the lymphatic vessels are compromised after breast removal. Okay, because the lymphatic circulation is affected when we remove those muscles of the breast. Complications now. So introduction statement is, although hemodialysis can prolong life, it does not alter the natural course of CKD. Does that make sense? Meaning all those anemia, bone problems, they're still there, right? So what is hemodialysis only doing? To prevent death and prolong life. That's it. That's the only purpose of hemodialysis. Quality of life, I don't know about that. Okay, I don't know if it improves quality of life because I mean the patient has to go for dialysis regularly. We'll look at the advantages and disadvantages. Okay, it's not it's not the. That's it. Yeah, prevent death. Yeah, that's it, and therefore it prolongs life. Yeah. So here are complications, especially if the patient misses the sessions. So heart failure, coronary artery disease, they could have a stroke or vascular disease. Okay. Okay. Again, even especially if the patient misses the dialysis sessions. So they'll have shortness of breath. Obviously, this is sign of fluid overload. Hypotension is always a risk after dialysis because you're removing so much in a short period of time. I mean, how do you lose? Because what is the weight equivalent again? So when the patient loses 1 liter, how much is that? 1 kilogram, correct? If they lose or gain 500 ml, how much is that? 1 pound, right? Okay. So if the dialysis nurse says, okay, I removed 4 liters. So how much is that? That's 4 kilograms worth, right? So do you lose 4 liters ordinarily day to day in a matter of 3 to 4 hours? No. So what will that have on the patient? Hypotension, okay? Because it takes a while for the body to adjust to the sudden loss, right? So where did all this go? Okay, where did all the fluid go? So the patient's body will take time to adjust because let's say I had dialysis today, and then my next dialysis is Saturday, right? Hemodialysis Saturday. So between Thursday and Saturday, what was happening to all my fluids? Accumulating. So the body was used to fluid overload. And then suddenly, in a matter of 3 to 4 hours, you removed all that. So how will the body react? Of course, hypotension. And manifestations of hypotension are decreased cardiac output, which is nausea, vomiting, meaning, sympathetic, right? Sympathetic stimulation. Cramping because of the electrolyte imbalances that could occur because removing potassium is sometimes a lot. Can't really control exactly how much we remove. And this one is site related, meaning the patient moved, or maybe the dialysis nurse did not secure the needle properly and it moved. Okay, either poked through the vessel. This is the vessel, needle is supposed to be inside, it poked through. Okay, poked out, or maybe poked somewhere else. Okay, because these are not catheters, these are solid needles. So of course they will poke through. It's a catheter, it's not likely to do that. Arrhythmias, as already mentioned, potassium imbalances or calcium or whatever other electrolyte imbalances. Air embolism, again, site related, or the dialyzer may have malfunction. Okay, air went into the system. Chest pain. This is a complication of chronic anemia. If you have chronic anemia, you're likely to develop cardiomyopathy. That's heart disease already. This equilibrium, this is a neurologic complication, again, because of rapid shifts between fluids and electrolytes in your body, especially after dialysis. So your job, since we're not doing the dialysis ourselves, we have to prepare the patient for dialysis. So let's start with what are we doing before we send them? So the dialysis nurse will call you early in the morning because they'll prepare for their patient. So they'll ask you, hey, how's the patient doing? And then they already have, which is silly because they have the chart open and they still want to talk to you. Hey, what's the patient's weight today? I said, it's right there in the chart, documented. What were the latest vital signs? It's right there. Okay, it's on Epic. Okay, you know what I mean? But I mean, just be professional. Just answer them. Okay, yeah, this is it. Yeah, yeah, it's fine. They'll ask, how's the patient doing? Yeah. Did you check the glucose this morning? Yeah, it's on there. Yeah. Okay. Many medications are removed from blood during hemodialysis, meaning the dialyzer will remove medications from the patient's bloodstream. So what is your responsibility if you're working day shift? Are you going to give him all medications that are absorbed in the bloodstream are going to be dialyzed and removed? So what are you going to do? Yeah, no, I mean, I'm talking about medications. Okay, so based on that statement, many medications are removed from the blood. So what are you going to do? Do we give it that morning? Doesn't make sense. You give it, it'll just be removed by the dialyzer. Does that make sense? Okay. So let's put it this way. I will only administer medication if absolutely needed. So let's say the patient's blood pressure is 220 over 120. Am I going to wait for dialysis to manage that? Of course, I have to give it now. Does that make sense? Okay. But if everything patient's basically, stable, expected, nothing life-threatening, I won't give any medication because what's the rationale? the dialyzer will remove those medications. Exceptions would be non-absorbable medications. Okay, so medications that are not really absorbed in the bloodstream, let's say antacids, for instance, they're not absorbed. Okay, so you can give those. They say a patient has an upset stomach. Go ahead, give that. Okay, because that's not absorbed anyway. So it's not going to be dialyzed. Does that make sense? Okay. And then after dialysis, it will still be your judgment. Or if you're not confident about your judgment, you can always consult the doctor. So you give only medications if they're safe to give after dialysis. Okay, so let's say, what did we say was the complication after dialysis? Hypotension. Okay, so we have hypotension listed there. So therefore, do you have to give the antihypertensive medication? Of course not. Patient doesn't need it. It's even dangerous if you give it. Does that make sense? So yes, as a rule, basic, except again for a few medications, let's say insulin has to be given. Because do you wait for the diet? That no, sugar is high. You have to treat that. Okay, so that's the exception. But everything else, especially PO medications, hold them. Okay, so you just put them on hold on your MAR, and then wait for the patient to come back 3 to 4 hours later, and then reassess which medications are safe to give, right? So you have to deal with each drug on a case-by-case basis. There's really no rule to, okay, give everything after dialysis. No, depends. What is the patient's condition? Okay, is it safe to give the medication? Now, not all, but some patients will receive albumin. Okay, not all, but some patients you may receive an order to give albumin, okay, after dialysis, but not really as a rule. Okay. Okay, so these are the medications that you have to make a decision on, because these are going to be removed by the dialyzer. Sometimes if the patient really has bad anemia, and remember, when you give blood transfusion to anemic patient, to a dialysis patient, can that cause fluid overload? Yes. So sometimes if that's the case, patient's blood pressure is so high, but the hemoglobin is low, they need a blood transfusion. Doctors usually will tell you, okay, tell the dialysis nurse to give the blood during dialysis. Okay? Because blood, is that dialyzed? No, red blood cells will not be removed. Okay? So you can safely give a blood transfusion, because what will be removed by the dialyzer? The excess fluid. Okay, that way, patient will not go into fluid overload, but they get the red blood cells. Sometimes also, they can also get, especially really strong antibiotics like vancomycin, for instance. They will be ordered also, okay, give it during dialysis. Okay, because vancomycin, 1 gram, for instance, is in a 250 ml bag. Okay, and then higher doses is in a 500 ml bag. That's a lot for IV, okay, for a dialysis patient. So usually we give those during dialysis. At least it's off your hands. You just hand the antibiotic to the dialysis. Here you go. Okay, that's for you. For outpatient, of course, the dialysis center and the patient's doctor will have already instructed the patient, meaning they're not in the hospital. They go to an outpatient clinic. So they're also taught the same thing. So they're usually told, don't take any of your medications. And sometimes they specify, don't take these, okay? Until after. We'll tell you whether or not you can take them after the dialysis. Diet, just follow the restrictions. Okay. The dietitian will give them a list and then give them suggestions. Yes, can the patient know, let's say if the nephrologist has told them, okay, your diet will be 70-gram protein, 3 grams sodium, 2 grams potassium. Will the patient know that? No, it will have to be the nutritionist or the dietitian that will give them a menu. Okay. Or sometimes the patient, let's say the patient has annual income of 30 to 40,000. Can they afford a nutritionist? So what will they end up eating? Fast food, correct? Okay, so if that's the patient's situation, the nutritionist will give them options. Okay, so you can afford only these, then they'll recommend like, okay, what do you order from the dollar menu, for instance? Okay, probably not, because I mean those things don't really have, the best nutrition. But I mean, there will be practical, realistic menu items, okay, for the from the dietitian, because we recognize the patient's financial situation as well. So the nephrologist will prescribe the dietary nutrition restrictions based on the patient's labs. The rule usually is, if the patient is on dialysis, let's say today's dialysis day, they're usually given more protein on dialysis days, because the doctor understands they lose some protein on dialysis days. So they'll be given extra on those days. Only in the hospital though. In outpatient, I have a few dialysis nurse friends. They said they give protein bars. Okay, like those granola bars. Yeah, they give them to the patients during dialysis. So they chow on them while they're having dialysis.
Okay.
Huh?
See ladies also in chemotherapy.
Cancer patients in general are malnourished. So we promote nutrition as much as possible. Psychosocial needs, it'll be the same from chapter to chapter. I mean, just imagine, what is this patient dealing with? Something incurable, yeah? And they're hopelessly waiting for a transplant, which may or may never come. Okay. And yeah, maybe they're the breadwinner, now they can't work. Okay, so they have a lot of S word to deal with, okay, in their family. So be patient if they have some attitudes during these days, okay, or every now and then. It's not about you. It's just their way of dealing with what they have. Because are you used to people wiping your butt? Being naked in front of 3, 4 staff members, and you being turned around like that, all your junk out in display. No, right? I mean, nobody plans, nobody does that, right? So this is a really stressful. So always think about that when you have a hospitalized patient. It's not the best day. So of course, some of them will react, and then act out because of that. Who knows? But always be understanding. Meaning, don't get angry, basically. Right? We're only human. Yeah, we will get angry too, but it's not how we respond. Okay. Okay, here's your teaching for hemodialysis in general. Okay, most of these we already discussed. Importance of daily weight, taking vital signs, diet restriction, managing medications before and after dialysis. As I mentioned, there is a home hemodialysis, but it's very small population, because we screen these patients for appropriateness. Not everybody will be a candidate. The patient must have the knowledge and skills in order to handle sophisticated equipment like this one. So it's not for everybody.
Is it a high risk for infection?
That too. We really don't worry about that, because in my experience, especially in home health, patients and their families are easier to teach than nursing students. That's the honest to God truth, because they have more interest in it. Their life literally depends on it. Okay, if they don't wipe, here I struggle with, watching you guys handle IVs, wiping. Did you wipe? Did you use this aseptically? I don't have to deal with that in the home setting. I teach the patient and I tell them what's the consequences. Yeah, they're really, especially the daughter, the wife, very protective. And when they go to the hospital and then another nurse handles it, and they'll be like that, like a whole, hey, you know, yeah, they'll say something. Okay. So that's what I mean by they're easier to teach because they have so much riding on it. Okay, so if they don't do it correctly, or as a student, I don't do this correctly, I get a do-over. Okay. They don't die, but the patient dies. So we'll skip the home dialysis because we're not doing that anyway. Let's go now to and then CRRT, as I described, this is only in ICU, right? Okay, so the ICU nurse, no, not the ICU nurse. It's a dialysis nurse that will be handling this as well. But the machine, of course, is different. So this machine will be doing it slowly over 23 hours. Okay, here is what you will be performing. So all RNs are expected to know how to do this. It's pretty simple. It's like you're doing IV earlier. Yeah. So we use alcohol, right? To wipe the port because this involves connecting port tubings to a catheter. Okay. Okay, so this is the option. How it works is because the dialyzer have a filter. Now the filter or the semi-permeable membrane here will be the patient's own peritoneum. Okay, that's what we will use. Still using the concept of osmosis, diffusion, and ultrafiltration. Okay. I'll go straight to the. Okay, so who would want to do this? Chart 48-11. Here are the advantages. You're not tied to a hemodialysis machine, meaning you can travel. Hemodialysis patients cannot easily travel because it's not like you can go to Vermont for a weekend, for instance, or a week, and then expect, okay, there are dialysis centers there, so I'll just walk in. Doesn't work like that. You have to plan it ahead, meaning you can travel, but requires advanced planning. So you tell your doctor, hey, we're taking a trip to Canada. I'll stay there for 2 months. So your nephrologist will say, okay, I know a couple people there. So they'll contact the place where you're going. Okay, who are the providers there? They'll send your records there, and then once you're accepted, then they'll prepare. Okay, so we got you. We have your records. Okay, we'll see you in February 28th. Okay, so just come over. You have our address. Okay, so that's how it works. With peritoneal dialysis, there's no preparation involved because the patient is doing this themselves. All right. So you can have control over your activities. You can eat a more liberal diet because with peritoneal dialysis, the patient loses more protein. So therefore, is there any protein restriction for these patients? Hardly nothing because they lose a lot of protein. So protein is even encouraged, okay, in these patients. Disadvantages. They have to do this 7 days a week, 4 to 5 times a day.
Whoa.
Okay, let me describe how it is. So again, the dietary, there's really no, here, they're even encouraged to increase protein and potassium in the diet rather than restricting them. Okay, who gets this? Patient is willing. They don't want to have hemodialysis. I want to be free. I want to do it myself at home. There's strong family support. The home environment is ideal, meaning they're not living in a tight mobile home, for instance. Okay, the place is clean. All right, because we have to evaluate here. A nurse will have to visit the patient's home. Is it ideal? for hemodialysis. So if they live in a small trailer, probably not a good a setting, okay? Because plus there's pets there, there's cats, 8 dogs, say 9 cats, each having 9 lives. Man, it's not a sanitary place to do a clean procedure. Okay, so sometimes we'll say, no, okay. And we'll tell them why, and then we'll say, okay, this is not gonna work. Okay. Here another reason, or this one. Contraindications. You can have this option if you have any adhesions from a previous surgery, chronic backache, because the patient will be putting in 1 to 2 liters of fluid each time. And imagine carrying 1 to 2 liters in your abdomen. What will that do to your back? Okay, so back pain, chronic back pain, not indicated. Severe arthritis, meaning they have swan neck deformities, because you need dexterity. You need to be able to prime a tubing, clean a port, attach it. Okay, you need fine motor skills. If your hands are like this, because of arthritis, can you do that? No, you can't even wipe your own ass with these, right? I mean, you can't drive a car, you can't close your buttons. How much more handle fine tubings? All right, so that's a contraindication. Okay, let's describe the procedure. So before you go home on peritoneal dialysis, you will be trained and the doctor will have to insert a catheter. Yeah, we'll have a picture shortly. Here's the picture. I'll go back to the procedure later. So you can see this, right? Yeah. Okay. So here's the catheter. Be surgically implanted, and a piece will be sticking out. And then you take that somewhere and you have it. So the concept is the peritoneum, like I said, will be the semi-permeable membrane. It will be like the filter in the dialyzer in hemodialysis. So we'll hang a 2-liter bag, sometimes 3 liters. This will be provided by a drug company. So you'll hang it on a pole. You prime the tubing, then you clean the catheter port. You attach the tubing to your catheter, open the clamp, and wait for that to slowly infuse. So this phase is called the inflow. That takes about 10 minutes. So you can do this on a pole, let's say, in the kitchen or in the living room, you attach it and you walk around with that pole, do about your business. You're cleaning, vacuuming. Okay, you're having the pole like this, or eating a snack or watching the game. So, and then once it's empty, you disconnect, then you walk around, do whatever you want. So the story I always tell is this can work in a theme park. Say you're in Disney World. I'll go to the bathroom, hang it somewhere. Okay. I have a hook, hang it somewhere. I have my bags. Hook. Clean it. Instill. I'm in the bathroom 10 minutes. Disconnect. I go on the ride. Plus, I have an illness, so I have a fast pass. More lines from here. You go on 3-5 rides, right? Because I have to keep this in here for about 2 hours. Okay, so the fluid that we call that fluid the dialysate. Okay, so I go around. It's even better. You go on a roller coaster because you need to spread the dialysate solution throughout the abdomen. It works better that way. But if you're at home, you can lay down, roll around, for instance, and then walk around. That's best. And then 2 hours later, you're gonna take the same bag. This time, you will drain it now, like gravity. So the objective is to remove more than you put in. So if you put in 2 liters, you should at least come out more than 2 liters. Okay, that's how you know it worked. If you get less, that just means something's wrong. Maybe the fluids are trapped between the bowels. Okay, so all you do is just move around, okay, try to drain that, press a little bit maybe, just to drain all that fluid. The fluid is supposed to look like urine. The solution will be clear or like water. The outflow, so that's the inflow, right? Inflow, and then dwell time for 2 hours, and then outflow another 10 or maybe 15 minutes. This will look like urine, yellow, because literally it's waste product, right? Just like your urine, that's what it will look like. If it looks cloudy, what does that cloudy urine mean?
Infection.
Same thing. It's probably there's an infection. It looks bloody. A little bleeding is expected, and it's on your textbook. A little bleeding is expected if this is new. Okay, for the first few sessions, first few days, it'll be a little bloody. That's fine. But if it continues beyond that, something's wrong. Maybe the catheter perforated something. So maybe it's stuck. The mesentery or a piece of bowel maybe have been injured. Take some blood, so you go to the doctor. So cloudy infection. Of course, you report that, right? Bloody, some perforation maybe, and then what if it looks brown? Brown, flush it down. So what is brown?
Oh, it's
It's perforated.
perforated.
bowel. Which is rare, but it could happen, especially if the patient's too rough. Catheter may poke and perforate a piece of bowel. And then you do that one session is called an exchange. Okay, so inflow, dwell, outflow. That's called one exchange. You're going to do 4 or maybe 5 exchanges a day. This will work. Okay. It will work. Okay, so you can go, normally, you can even hold a job or you're in school, although you'll be gone for about 30 minutes total because you do your inflow. Maybe you can do it right here if you don't mind.
You don't space it out throughout the day, back to back.
Well, that's the deal with this. You have to do minimum number of exchanges, but otherwise it won't work. But we're only removing small amounts. Unlike hemodialysis, where we're removing it one time a lot. That's why it's every day, because you're removing small amounts only. Will this work for you? Sequentes? You just do hemodialysis? Okay. So here's the so preparing the equipment, like I said. So you'll be given a lot. Okay, so you have boxes of these things at home. Because you do this every day. So it'll be a lot of delivery. So probably fill up a whole Amazon truck. Okay, or maybe half of that just for your delivery. Complication with this, especially if you're careless. Okay, so it's peritonitis is your number 1 risk factor. Okay, infection, which can lead to sepsis. So one exchange, again, there's the inflow, dwell, and then outflow. So that's one exchange. So inflow is 10 minutes, and you're expected to put in 2 or maybe up to 3 liters each time. So you're gonna be carrying that 2 liters right here. While you're shopping, ShopRite, Stop and Shop, wherever you go. Yeah, because grocery shopping takes about an hour or two, right? So perfect for dwell time. You go home, drain it. Then after the second exchange, you go to the bank. Okay. Whatever errands you need to do. Go Home Depot. All right, complications. I mentioned peritonitis, serious. You could die from sepsis. So that's infection of the peritoneum. Leaking. Yeah, from the catheter site. Leaking. Bleeding, as I mentioned. Long-term complications, we have the back pain, also some breathing problems, okay, because this can put a lot of pressure on your diaphragm. Plus, we don't know how big the patient is. So if the patient's already obese to begin with, then you add 2 to 3 liters more, that's a different story, yeah? You could have hernias, yeah? Yeah, because of the increased abdominal pressure, it could create hernias. I already mentioned the back pain, okay? There is an automated option. So what I described to you is called CAPD, continuous ambulatory peritoneal dialysis. So that one is the most cost effective, meaning all insurance company will cover that. Okay, no cost to you. Cheapest. When it involves a machine, however, because now we have automated peritoneal dialysis machines, this one will be done by a machine. A period of 8 to 10 hours. So how it works is usually patients go about their daily activities, now go to school, go to work. When they come home, they attach themselves to the machine, and the machine will do the dialysis while they sleep, peritoneal dialysis. Like I said earlier, so if you get less drainage, you just move. You try to move that because the fluid will go everywhere. So they may get stuck somewhere. But a warning, the catheter must never be manipulated. Try to pull or push on it. Just leave the catheter alone. Just move your abdomen. So that's CAPD. And we have the continuous cycle. Okay, so this one is automated. And that's it. Any questions on peritoneal dialysis? There are very few people, obviously. Fuentes already said this is not going to work for him. Honestly, in my practice, I've only seen one patient doing this, and it was in Florida. Yeah, just that one time. That's the only time I was able to use my skills for peritoneal dialysis. Then never again. Yeah, my patient. And that's the only time. Because normally she does it herself, but because she was sick, 2 weeks, so I had to do it myself. 12 hours. But I was night shift, so I only did 2. But the day will have to do 3. Because sometimes the last exchange is when they sleep. Like we infuse one dwell and then we leave them alone because we can't be waking the patient. So she has to sleep. So when she wakes up, then I drain it. That's the last exchange usually. Okay, so the last exchange for the night will be they'll keep it, they'll sleep with it, and then drain it in the morning when they wake up. So there's a lot of logistic problems here. Let's say you live in somewhere where you have a hurricane. Logistics will be a problem. Okay, because you think a drone can carry these heavy bags? Probably not. These are big, heavy boxes of liquid. Maybe the drone can carry one box. Yeah. Okay, so here are your going back to the fistula. So you need to assess for a bruit or a throat. A bruit is a sound. So you listen, you put your stethoscope over the fistula and you'll hear whooshing of blood. Thrill, you palpate. You feel it will vibrate. Literally like woo as the blood passes through. It's a huge blood vessel. So you will be able to feel the blood flow. Okay, and then you have to document that. If there's no thrill or bruit, that's a problem. So you call somebody. Okay, you call the doctor. Could be that there's no bruit or thrill because it's blood flowing through it. No blood flow. So it could be a clot or something mechanically obstructing it. So you call somebody. Because what did we say these axillary access devices are? Yes, because dialysis will prevent death. Okay. Then you have to emphasize and say it like this: death cause death. So, people take it seriously. What will happen? You'll be dead. We need that. Last warning, be careful whenever you receive orders for IV fluids for a patient on dialysis. Always take that with a caution. Okay, meaning why fluids? Why? So ask the doctor, why are you ordering fluids? Okay, don't just say, oh, it's ordered, I give it. No, always ask why. And if you're satisfied with the reason, then give it. Okay. If not, don't give it. I mean, see, because patients on dialysis cannot excrete water. They're not making urine. So where will that fluid go? Exactly. So always be cautious when there's IV fluid ordered for a patient with dialysis. Antibiotics, fine. Okay, IV antibiotics, of course, it's necessary. But IV fluids, continuous infusion, I would be cautious about that. Why? Sometimes it's necessary. Let's say patients really came in with dehydration. Yeah, of course. Yeah. That will the labs will support IV fluids, but just make sure it stops at some point. Okay. I mean, how much fluids are we giving actually? Can't be like days. Okay. Maybe a few hours, maybe 24 hours at the most. Like I said, we'll discuss pericarditis later, because that's a big concept. As I mentioned earlier, the patient may receive albumin infusions, but not routinely. Okay, but sometimes you'll receive an order for albumin IV. Okay, the site, by the way, will be itchy because the patient's skin, because of the chronic uremia, they have waste products in the blood all the time. The body will start excreting it through the skin. So these dialysis patients' skin will be dry. They have a white crusty powder on them. If you lick it, it's actually tasting salty. Okay, it'd be a little bit sour and salty. So perfect for tequila shots. Okay. So how do we take care of it? Because it's itchy, so the patient will scratch it. So you give them antihistamines and then wash it off, wipe it off, and then put lotion. Okay, because it can dry the skin as well. Because once they start scratching, now you have a wound, okay, especially over the access site. Now, when you stick a needle and then there's an open wound on it, yeah, infection. Yes.
Can you use hydrocortisone?
If it's medication, it has to be prescribed by the doctor, but no problem with tablets because it's not gonna go on the skin. But it's the, when you apply it, because now you need an order. Blood pressure, that's already been given. Again, these patients are high risk because that's a hemodialysis. So how many times do they have invasive? 3 times a week. Okay, so it increases their likelihood of infection. Okay, caring for the catheter site, it could be the tunneled or non-tunneled, or this could also be the peritoneal catheter. No special care for it, just soap and water. Okay, we just encourage the patient, okay, go shower, okay, and then wash the catheter as well, soap and water. Oh, no bath, by the way. They can't bathe. You can't soak the, you understand? Shower is fine, but no bathing. Okay, because what will bathing do? Yeah, we'll soak it, and now you have, whatever germs you have now goes into the catheter. So no bath. Medications we already addressed earlier, and psychosocial support. Okay, that's it. We'll discuss kidney transplant next semester. Any questions? Take a break, come back